Good afternoon and welcome to this ABBOTT-sponsored symposium, which is part of EBC 2020. My name's Adrian Banning and I work in Oxford in England. It is my pleasure to be joined by Carlos Collet from Aalst, Nicolas Amabile from Paris, and Gabor Toth from Graz in Austria. And we're going to talk about complex bifurcations, combining the latest evidence and tools to simplify your treatment. We're looking forward to understanding slightly better some of the pathology that's going on in this particular patient's bifurcation and exploring how imaging can help guide our therapeutic approach. So perhaps without further ado, let's ask Carlos to show us the case and we can try and understand a little more about what the challenges are. Carlos, thanks very much for presenting the case. We look forward to hearing your presentation.
Thank you, Professor Banning, for this introduction. And indeed, we have prepared an OCT-guided bifurcation stenting that we consider to be very complex, not only in terms of technique, but also on the pathology that lies behind the case that we're going to show in the next slide. So this was a 70-year-old male with a BMI of 25, typical risk factors, hyperlipidemia, hypertension, ex-smoker. He presented with stable angina class 3, and relevant past medical history was an anterior MI in 2003 that was treated with a PCI, with the LAD and the diagonal branch, and this was a two-stent strategy back then. Concerning the paraclinical information, normal renal function and normal ventricular function. This was the ECG before the procedure. You'll see normal appearance of the anterior wall in terms of thinking of the previous STEMI. This is the angio. You'll see immediately that there is a stent in the LAD and you'll see a severe restenosis just at the ostium of that diagonal branch, which is a big diagonal branch. You'll see not only it's in size, but also in extension, in the length of the vessel. And you'll see a very critical lesion at the level of the bifurcation. This is our in-stent restenosis, Medina 111. This is the still image to appreciate a little bit better the morphology of this severe angiographic stenosis, which has the very minimal luminal diameter at the level of the bifurcation. But if you go also proximally in the LAD, you will see that the disease comes from the proximal part of the vessel, almost from the ostial of this LAD. So we perform an OCT to better understand the pathology of this in-stent restenosis. This was a very challenging OCT acquisition, but we didn't want it to predilate the vessel to better understand what was indeed the cause of the restenosis. So we did a double injection. This means from the catheter and also from the flushing port of the OCT catheter to be able to opacify the vessel distal to the stenosis. And this is what we got. We got, these are the cross-sections. You will see cross-section A in the very proximal part of the LAD, which is a huge vessel. Not healthy. You will see a couple of calcified plaques there at 12 and coming from 12 to 4 o'clock. Then you see cross-section B, which is actually at the level of the minimal lumen area. It was 0.68, a very tight luminal area there at the level of the bifurcation. And you see the appearance of this restenotic lesion, which we will discuss further on with the expert. You will see this heterogeneous appearance of this, what appears to be severe neointima hyperplasia. Then you will go down across section C, and we were happy to see that we could see the entry of the diagonal branch. You will see that at 6 o'clock, and you also see the stent struts. And in this cross section, it appears that we have some underexpansion at the level of the take of the diagonal branch. And finally, cross section D, which also showed the previous stent that was implanted with a mild amount of neointima hyperplasia. This is the 3D reconstruction coming from the OCT, again, to try to identify the position of the ostium that we thought it was the most challenging part of the procedure.
So I guess the questions for me are, and you may not know this, Carlos, and often we don't, do we know what bifurcation technique was used in the original revascularization?
Yeah, we didn't have that information, unfortunately. So we were not aware. We thought it was a tap by the configuration of the stent in the angio, but we were not sure of the technique that was used.
I think we can take it as a given that this is an important diagonal. As you mentioned, it runs long, and we've heard over the years that the length of the diagonal is really very important with regard to predicting whether that's going to be an important diagonal for us to look after. So we do want to try and get a good result, a good angiographic result, and more importantly, a good functional result in the diagonal, as well as the LAD. And I guess the other question is, can we wire it? And on the angiogram, and certainly on the OCT, you would think, yeah, it looks okay to wire. Everybody has their own preference. For me, I always wire the most difficult lesion first. And so my wire would go into the diagonal first. I probably wouldn't predilate to begin with, and I would just try and get my 2 wires in. But you can see from the RAO projection in the angiogram, it certainly looks pretty tight. Perhaps before we talk about the PCI options, we should just go through the process of confirming that PCI is the way forward. Nicolas, is your view PCI or surgery? How would you judge that?
Adrian, I think that's a great case. It's a very challenging situation, and my initial plan would not to treat this patient with cabbage, but rather do a PCI. And so, of course, the challenge is that there is already one layer of struts within the artery. So I would try not to put other stents in this previous stent, and maybe analyze the reason for the in-stent restenosis and potentially go for drug-eluting balloon after OCT and potentially also post-dilate the previous stent.
Great, thanks, Nicolas. I guess, the key question for me here is whether the initial stents are properly expanded or not, and what the contribution of in-stent restenosis is. It's interesting that this is, this is a long time since the stents were placed, so it's slightly unusual presentation. This is some 10 years or so, I think, since the original stents. So imaging, Gabor, for you, I mean, sometimes we are perhaps put off imaging when the disease is complex. Do you think imaging is mandatory in this case?
Yeah, I think it's a real challenging case, but we are facing more often such cases where the patient comes with a restenosis and a bifurcation, and you have no information about what kind of technique was used. And I believe in such cases, imaging can be really helpful. It was demonstrated here by Carlos that we don't see much double or triple layer in the proximal main branch, which helps us actually to exclude more or less DK Crusher's previous technique or Culotte's previous technique. So we can assume that it was probably a T with very small or almost no protrusion. And so for this reason, I believe it was a huge help to see with the imaging as a starting point to understand the previous anatomy. As shown in this slide, which comes from the Light Lab data, Light Lab was, I don't know whether you know or not, Light Lab was actually a project by ABBOTT where in selected hospitals, very systematic use of OCT was done during all kinds of procedures, following a very strict rules or guidelines, how to do and how to react on different findings. As you can see here, even in bifurcations, it was quite large number of cases where the OCT-derived information completely changed the practice or changed the previous strategy of the operators as it was used before the PCI or during the PCI. I'm sure that in this case, the use of imaging, it helped a lot to clarify some unanswered questions of the end.
Carlos, just tell us again how you managed to get such good pictures in this very tight, very severe stenosis.
Well, that was, so I'm going to disclose the technique, and this was taught to me by Dr. De Bruin. And we used the port that we normally use to flush the OCT catheter, and then we inject at the same time through the guiding catheter and through the port of the OCT catheter. So this allows to opacify proximal to the severe stenosis and distal to the severe stenosis, and then you manually start your OCT pullback, so you have a complete picture of the vessel, even in severe lesions.
And the patients tolerate that pretty well?
Pretty well. We have no issue with the patients with this technique.
Great, because they are spectacular pictures given the severity of the stenosis. Nicolas, drug-eluting balloon versus a second stent. Clearly, because this is, I guess in this case, a third stent, because this is a bifurcation, it does have a, we've all put stents 2 more stents inside 2 existing stents. But it can be difficult, particularly maintaining wire access to the branches. Which technique would you favor? Would you prefer to try and treat this with a drug-eluting balloon if at all possible?
I think when we get in-stent restenosis, it's very important to perform a RCT to analyze first if it's neointimal hyperplasia or if it is neoatherosclerosis, because then the treatment will be quite different. And so also to analyze the reason for intrastent restenosis. So that's why I think that RCT is quite indicated, and especially in bifurcation, because it will really help the operator to get a better choice for the treatment. And so in case of first episode of intrastent restenosis related to hyperplasia, neointimal hyperplasia, drug-eluting balloon is a quite correct stent. But in case of neoatherosclerosis, I would personally go more for a drug-eluting stent.
Great. So, Carlos, you've heard the opinions of our colleagues there. I think broadly you have strong support for the approach with regard to imaging. And I think we all feel that if we can avoid putting further stents into this bifurcation, that would be preferable. I guess the fact that we think that based on the OCT, this may be a TAP or perhaps a T, more likely a TAP, I guess it possibly implies that wiring may be slightly more difficult. But let's see what you said. Also, you said you did.
So I think we are in agreement with the panel, and this is exactly what we plan to do. So the plan was to wire the main vessel, to wire the side branch, to predilate both branches, and finish the procedure with a drug-coated balloon for the main branch and the side branch, and then do a final OCT run to assure that the stents were well apposed and we didn't have any areas of other expansion. So we really agree with the notion that we have to avoid an extra layer of stent in a bifurcation that was already treated with 2 stents. So this is what we did. So we started wiring the main branch, which was fairly easy, and we did a predilatation in the main branch with a 2.5 15 balloon, and then we went a little bit higher with a 3.5 20 balloon. This is for the main vessel. But we have some issues accessing the side branch, and we tried initially with the normal wires. Then we decided to park the balloon just distal to the takeoff of the side branch to see if this would help. And then we start trying different wires. Start with a BMW, then we change to a Whisper, then we use a Pilot, then we use another time a BMW, but none of these wires would go into the diagonal. We went into, we used a filter as well, and it didn't work. So finally, we decided to use a microcatheter, a Super Cross from Teleflex, which has a 120 degrees angulated tip. And using this microcatheter oriented towards the ostium of the side branch and using a Gaia first, we were able to go inside the diagonal, as you see in the right picture of the LIO cranial. We will finally were inside the side branch. We had some issues trying to cross this side branch with the balloon. So we use a guide extension. You see the guide extension there coming inside. We started with a small balloon at 2.08. And this is the first angiographic result that we had in the side branch. So we were really happy that we were able to cross the side branch, and we have good flow with a relatively good angiographic appearance at this stage of the procedure. So we started to increase the size of the balloon. We did another predilatation at the ostium of the side branch with a 2.015. And then we did a kissing with a 2.5 in the side branch and a 3.5 in the main branch. And let me show you, then we decided to continue the procedure with a drug-coating balloon in the main branch. This was actually to avoid the extra layer of a stent. And we performed an OCT after the drug-coating balloon in the main branch. This is the run of the OCT. And when we look at the still pictures, this is what we observe. You see, if we start from the distal part of the vessel at cross-section D, you will see that you can identify some of the previous struts that were implanted, and we have a small dissection at 6 o'clock. If we move a little bit more proximal towards the ostium of the side branch, you will see that we have a dissection which was inside the previous implanted stent. That means a dissection in the neointimal hyperplasia with some thrombus and thrombotic appearance at this stage, and you see the ostium of the side branch at 6, 7. But in the most proximal part of the vessel in the LAD, we have a huge dissection, and you can see that in cross-section B and cross-section A. We think that this was due to the guide extension that went pretty deep into the LAD to be able to cross the diagonal branch. So finally, we decided to implant another stent proximally, and this is we implanted a Sierra, a 4.0, 18, guided by OCT. And here is the last run of the OCT in the main branch that show a very good expansion of both the previous and the new implanted stent and no areas of malapposition. If we look now at the still pictures of the same final run, this is what we obtained with an MSA at the level of cross-section C of 8.74 millimeters square. And this was the final angiographic appearance, which for us, it was really gratifying to see a very good flow in both branches and a good result at the level of the side branch and at the main branch as well. Finally, the patient did well. Small increase in troponin after the procedure, 30.6, and small changes in the anterior wall, but without pain and without further increase in heart enzymes.
That's a great case. And I think one of the things in intervention that we love, of course, is that there are guidelines where we must do stuff, or at least we feel very strongly that this is the way to do stuff. And then there's lots of elements where, our practice is more of an art than a science. And I guess what interested me was that you chose to kind of be quite aggressive with the main branch before trying to wire the side branch. Were you surprised then? What do you think the mechanism? Why was it so difficult to wire the side branch when actually, on the OCT originally, we thought the side branch looked as if you could see down there? Did that surprise you? Did you feel that you were behind something?
Well, we had the impression that when we start changing the wires and we finally went with the Gaia one that has 1.7 grams of the tip, that we were kind of puncturing through something. It was not a smooth cross towards the side branch. And when we actually passed the wire through the distal part of the side branch, we were kind of confirming that we really were in the true lumen, and we're a bit afraid that we were maybe in suboptimal space because of the feeling when we went into the very ostium. So I'm not completely sure that we actually went to the small lumen that we saw in the PrePCI OCT, but we indeed found another channel to go into the distal part of that big diagonal.
And as you say, it's all then about making sure that it doesn't really matter to a certain extent, as long as we get into the distal lumen, and then making sure that we've expanded the area of the bifurcation and the carina optimally. And you obviously got nice images with that. And then making sure that the main branch is right. And I think one of the things that we sometimes, one of the risks here is that we get our eyes completely transfixed on the ostium of the diagonal, and we forget that actually, making sure that the main branch proximally is optimized is hugely important, and there's lots of obvious good data confirming that statement. So Gabor, what were your thoughts about the way that this is, the way that Carlos has managed to treat this bifurcation?
It's a different story as compared to when you see a native de novo stenosis and you have to select the technique. This patient has already a layer of stents in the side branch, a layer of stents in the main branch, and now you just go to optimize, or at least could correct the results of that. I think the most important thing here is to avoid adding multiple layers to that. So I think the approach with the balloon and drug-eluting balloon is a really good choice. Of course, you have to see whether after lesion preparation you have a good enough result to go on with drug-eluting balloon. But as long as the lesion preparation allows you with its result to go for drug-eluting balloon, I think limiting the layer of metals, it's a very good choice. Yes, so my question is that you used OCT in the main branch after lesion preparation, but you did not use it after wiring the side branch. And wiring the side branch was extremely challenging, as you demonstrated, different wires, different techniques. And in case of complex bifurcation, my greatest doubt is always whether I wire the side branch properly, or in this case, when you have already a stent in main branch, stent in side branch, I would have fear that I might wire the side branch behind struts or not through the cell what I really wanted to. So I believe imaging after side branch wiring is a very good way to understand what we really did, whether we placed the wire to the proper direction. So my question is whether you considered to do this, or you were confident enough that your wiring was through the right direction.
I guess, Carlos, before you answer that, it was a question really of having struggled that hard to get it in, that's where it was going to be. It wasn't as if, I suspect you weren't likely to pull it back out and try and redo it once you'd finally got in there with your fifth wire. But tell us what you think.
So I think imaging the side branch is, it was something that we thought in the procedure. We even tried to pass the OCT catheters to the side branch, but it was not possible. There was something at the ostium of the side branch that impeded the OCT catheter to go through. So we didn't try a lot, to be honest, because we didn't want to, we want to preserve our OCT catheter, and this was all through a guideliner. So we decided to stop pushing the OCT in the side branch and just rely on the angiographic result.
Carlos, I've got a question for you. Would you consider about, if you go for drug-eluting balloon, do you consider just treating the main vessel, or would you also treat the side branch with drug-eluting balloon? And if not, okay, could you explain us why only the main vessel?
That is a very good question, Nicolas. And the initial idea was to do a drug-coating balloon also at the level of the side branch. But again, we had a lot of difficulties pushing down the drug-coating balloon for the side branch. So we decided to do normal balloon for the side branch that looked pretty good angiographically, and end up with a drug-coating balloon only at the main branch.
I think one of the relevant comments I would make about that is, going back to the natural history of this, it's quite possible that there's been an element of restenosis here for some years. This is not a procedure that was done 9 months ago. This was a procedure that was done many years ago. And it may be that this patient's been pretty well with an angiographic result, which was not perfect for a long time. That I think has a bearing on my approach here, that I might not be looking for angiographic perfection. I want that diagonal to be open, and I want it to be as good as it can be, but I'm not striving for angiographic perfection in the branch. I want to make sure that the main LAD is absolutely optimized. So, Gabor, you have a question for Carlos?
Yeah, my question would be here. Actually, no, it's not even a question. It's more a comment that I believe that with imaging, you understood very well what is the extent of what is the extent of proximal dissection, and to what extent you need to stand proximally to cover it. I believe it was again a kind of confirmation what we have seen on the angio and confirmed by OCT. I think here again post-PCI OCT might add some important information regarding how far you need to post-dilate and optimize the stent result. Final question is again that you have a very nice results proximally and in the main branch, but whether you consider to do OCT in the side branch as well at the final result, just to understand whether you have a good apposition all over the bifurcation.
Thanks, Gabor.
So yeah, we're really happy with the results on the main branch, and just to give kind of a summary of where the level of decision in this case. First, we identified that it was neointimal hyperplasia. Then we were confident to use the drug-coating balloon. Then came all the technical difficulty of the procedure, but then we finished with an OCT that showed a very extensive dissection. And as you mentioned, Gabor, the length of the dissection was extremely important for us to select the length of the diameter. The next critical question at that level was, until when are we going to put the stent in the proximal LAD? So we aim to have a small amount of overlapping with the previous implanted stent. And this was kind of the decision that we took at that moment. The side branch looked pretty well. We have a very good flow. Angiographically, the ostium was not tight at all. So we were really confident that the result of the side branch was good. So we decided to end the procedure with the OCT in the main branch.
I mean, the other thing which is quite nice is that you accepted a little bit of a dissection distally on the OCT without feeling the need to put another stent in. And one of the criticisms of OCT is that we see too much and that we are kind of driven consequently to put in stents when they're not necessarily required, and that we can see small dissections, and perhaps less experienced colleagues might be tempted to put more stents in just because there's a dissection. Is that what, do you want to make a comment on that, Carlos?
Yeah, that was absolutely crucial, Professor Banning. The decision of the length of the stent in the main branch at the final run was something that we stopped for a bit, discussed with the colleagues that were also on the table to decide, okay, we have a long dissection. Actually, in the distal part is within the previous stent. It's not a big dissection, but the proximal LAD, that is, let's say, a de novo lesion, has a huge dissection. And then it came the discussion from where to where. And then we decided to cover the big dissection and then just landed just a few millimeters overlapping with the previous one and leaving, as you mentioned, small dissection in the distal stent untreated.
Nice. So going forward, dual antiplatelet therapy, and increasingly we have the option because of the stent technology we now have to start to tailor the duration of dual antiplatelet therapy for our patient and for the stent and for the procedure that we've undertaken. So, Nicolas, how would you kind of balance the requirements for this particular patient?
I was, of course, in this case, in this kind of patient, is a stable patient, so we treat him with a drug-eluting balloon and drug-eluting stent, and 6 months might be enough according to the European guidelines. On the other end is a bifurcation, so there's a high risk. There is a high risk for a recurrent ischemia, and so we could potentially consider longer DAPT, especially because the bleeding risk of this patient is quite low. But I was also very interested by the OCT image that Carlos showed, and especially with the thrombus on the struts or the protruding material just at the carina. And I was wondering if it will influence his peri-procedural anticoagulation regimen, if we'll go for more heparin or maybe a more aggressive DAPT strategy.
Yeah, so intraprocedural, when we see this amount of thrombus OCT, it's like a reflex, and we take immediately an ACT. We see thrombus, take an ACT, and most of the time it's a bit low, so we indeed add a bit of heparin to the procedure. That is something that we kind of, is a reflex now in the cath lab for us. Concerning the APT, we had the impression this is a gentleman with a complex stenting. We dilated the struts of a previous 2 stent techniques that we're not really sure what it was. We ended up with a proximal stent with some residual dissections. In that sense, we prescribed the APT for 12 months for this gentleman.
Yeah, I mean, that sounds very sensible. Particularly, I think it's easy to forget, in a case like this, you've got a guideliner catheter in, you've got OCT catheters in, that the potential for thrombus, obviously in the lesion is one thing, but the potential for thrombus in our equipment is another that we need to be very, very careful about. And when we're doing these complex cases, serial ACT measurements are obviously very important. Well, I think we've really learned a lot from that case. Carlos, thank you very, very much for bringing it to us. And thanks very much to Gabor and Nicolas, and to ABBOTT for sponsoring this session. I think what we've seen here is examples really of the kind of cases that we now, I guess, are the new routine. We don't have all the information about how this patient was treated some years ago, and how we, by using OCT in this particular case, took a case which was complex, got some really informative images from OCT, and that then allowed us to do ultimately what was quite a simple procedure. We haven't made it more complicated than it needed to be. We've ensured that the main LAD has been absolutely optimized. We've ensured that stent's been put in properly. and that we've got as good a result as we can achieve in a pragmatic way in this bifurcation. So a great example, I think, of how using technology, we ultimately managed to keep it pretty simple. So with that, I'll thank you for your attention, and I hope you enjoy the rest of the virtual EBC 2020.